Hi, this is Dr. Sham. I'm a rheumatologist practicing in Chennai. So we saw what all things can happen with psoriatic arthritis. Like what are in the previous yesterday's video, we saw it's not just the joints, it's about the skin. Even in psoriatic arthritis, patients can have involvement of the eye, what we call uveitis. They can have diarrhea, like they can also have inflammatory bowel disease, even in psoriatic. But the common things are it's the spine involvement is there, hand joint arthritis is there, whether skin is there, nail is there, enthesitis, that heel pain is there. For example, there are other places of enthesitis also. Then there is dactylitis is there. So the drugs which we use are, initially we use a painkiller called non-steroidal anti-inflammatory. Again, I'm telling, non-steroidal, it's the initial drug or a temporary drug. It's not the treatment for psoriatic arthritis. Usually we start with the conventional drugs like rheumatoid, like methotrexate or leflunomide. These are the conventional drugs. Now we have drugs like apremilast. If we are not able to control with it, then we go to the injectables like biologics or TNF blockers. In biologics, initially we got this group of drugs. Now we have other groups of drugs like IL-17, 12, 23 also. Now, with the new molecules, something called small molecules, JAK inhibitors, there are other drugs like tofacitinib. These are also have been approved in psoriatic. So to control the disease, we have initially always we start from below and go up, usually unless the patient has a very bad disease activity. So start with the conventional drugs. If it is not possible, then we escalate to biologics or small molecules. Dictum is this: we have to control the disease at any cost. Patient shouldn't be having any joint pain or joint inflammation minus a painkiller. That is the end result. At the same time, without having any side effects, with the safety profile also to be taken into consideration. So whether we use one tablet, two tablets, or biologics or small molecule doesn't matter. Even for rheumatoid or psoriatic or any disease inflammatory, controlling of the disease activity is important. Patient's inflammation should be under control, minus a painkiller. In psoriatic, if it's a rheumatoid, minus a steroid. And the other thing is we also have to keep looking in the safety profile, because as I told, in psoriatic, the common thing we encounter is something called fatty liver, patients being overweight or obese, not able to use the conventional drugs. So we might have to go on to a biologics or the newer small molecules. So without causing any side effects or without averting the risk of side effects, we have to treat the patient. So that is the most important thing. So this will be the multifaceted treatment. So with these newer molecules, definitely management of psoriatic arthritis has become much easier, and patients do lead a normal quality of life with both the skin and the arthritis and other components being under control. Thank you.